And I've been a respiratory therapist for more than 30 years. Currently, I'm working as clinical manager of ventilation at Medtronic. Today, I'll be your moderator for our conversation with Dr. Georgopoulos. Today, we're going to talk about proportional assist ventilation plus software. Dr. Georgopoulos is professor of medicine and head of the Department of Intensive Care Medicine at the University Hospital of Heraklion Medical School. Dr. Georgopoulos, what excites you about the use of proportional assist ventilation plus software?
The first thing is the proportionality, meaning that when the patient needs more pressure, the ventilator will provide more pressure. So, on the other hand, when the patient needs less pressure, the ventilator will provide less pressure. And this is proportionality. And this is a good thing for the respiratory system, especially for control of breathing system.
Why is it better for the patient to breathe proportionally on a ventilator?
Because basically you permit the control of breathing system to be expressed. And this is very good because the control of breathing system can protect the patient from high tidal volume or from low tidal volume.
So following up on that note, how do you think proportional assist ventilation plus software fits in with lung protective strategy?
The good thing with this kind of software is that we have the ability to measure compliance, and because of this we have the ability to calculate driving pressure. Today we know from several studies that driving pressure has a lot to do with outcome. And there are studies showing during passive mechanical ventilation, high driving pressure is associated with bad outcome, meaning increased mortality. PAV is the only mode during assisted mechanical ventilation that permits to calculate driving pressure. And this is very important because driving pressure can guide the physician to do some actions in terms of switching mode or changing the percent of assist or changing PIP or whatever.
Do you use proportional assist ventilation plus when you're weaning patients that were formerly ventilated on another breath type?
Yes, we use proportional assist a lot, especially in patients recovering from ARDS. Because in these patients we have the ability to titrate PIP and to see the optimum amount of PIP.
So when you're switching a patient who has had ARDS and you're switching them to a spontaneous mode of ventilation, how will you know if it's the time to switch that patient? Like, what are you looking for to know if this patient is ready to move to spontaneous breathing?
This is a hard question because we don't know from the beginning what is going on in terms of respiratory drive. So in the beginning we have to pay attention in terms of respiratory drive, meaning we don't want to have patient on assisted mode having very high respiratory drive because this may cause problems in terms of high tidal volume. It is important to think every day if this day is the day that we have to switch to assisted modes. And there are several variables that we have to deal before deciding that, okay, this is the day that we have to switch to assisted modes. These variables are oxygenation, clinical examination of the patients, very important, and if we have some clues that there is resolution of the cause that actually was responsible for the acute respiratory failure of the patient. So it's a matter of clinical examination plus observing some variables.
So are variables like the patient's temperature or the metabolic status important?
Of course. I mean, if the patient has high fever, it is not appropriate to switch to assisted modes, because high fever is associated with high respiratory drive. Not always, but in some patients.
So could you describe for me when you're switching, so you're on a passive form of ventilation, and when you're ready to switch that patient to spontaneous breathing with proportional assist ventilation plus, what process do you go through?
I mean, the application of PAV in this type of patients. Okay, in the beginning we dial a little bit high assist to be sure that we are going to support the patient. However, it is very important to realize that in this process, PEEP titration is very important. So, with PAV, the beauty of this mode is that with PAV we have the ability to know compliance. And by changing PEEP and observing the compliance, we have a lot of information about the triggering function and about the pressure volume curve of the patient. And this is important.
So you're using the compliance measurement then to adjust your PEEP level?
Exactly.
Okay.
Exactly.
So the process that you would go through would be you would take the patient from passive ventilation, you would lighten the sedation, switch them over to proportional assist ventilation plus, watch their driving pressures.
Exactly.
And when you describe watching the driving pressure, how are you arriving at that value?
It is very easy because driving pressure is the ratio of tidal volume to compliance. And because the ventilator, the software measures compliance, so we have both. We have tidal volume and we have compliance, so it is very easy to calculate driving pressure.
How long do you let a patient stay on PAV Plus before you make the decision that they're going to stay on it until they come off the ventilator? Or, as you were describing this process of looking at driving pressure and looking at the patient effort, how long do you wait in that situation before you make a decision one way or another?
I mean, when we have a patient with high driving pressure, we have to diagnose which is the cause of high driving pressure. So, if the patient has some extra lung causes of high drive, we should correct this. I don't want to wait for a long time with a patient having high driving pressure. So I would like to decide immediately or in few minutes or in 5 or 10 minutes what I have to do. So immediately I have to check for delirium, important. I have to check about metabolic acidosis, if there is ongoing infections, if there is no resolution of the initial cause that actually lead to respiratory failure, and if there is distress of the patient due, for example, to inappropriate low levels of PEEP. Okay, so there are a lot of causes, but we have to think about the relationship between high driving pressure and causes that lead to high driving pressure.
So you're going to assess that patient for any causes that are from within them, and then you're going to look at the ventilator to see is the ventilator because of too low of a PEEP level or something
Exactly.
causing this patient to breathe excessively.
Exactly. And in medicine there is no black and white, okay? Because in medicine you have to see every patient by its, individually,
Right.
okay? Because nowadays we have switched from guidelines to personalized medicine.
So there have been some studies published that have spoken about the danger of spontaneous breathing for a patient who is critically ill with ARDS. Could you describe to me how you are using proportional assist ventilation plus, applying it to patients who have had ARDS, and guaranteeing that you aren't causing pendulum effect for those patients?
I mean, pendulum effect is important and is associated with high drive. However, we have data showing that in a great number of patients, we are not seeing this problem with PAV. Indeed, we have shown that very few patients have driving pressure more than 12 or 13. Usually, the median numbers of driving pressure is approximately 10. And most of these patients were recovering from ARDS. So our data have shown that in very, very few patients we're going to face the problems of high driving pressure because of very strong inspiratory effort.
Okay, so it sounds like you have a mechanism for identifying when pendula is a possibility. And so would you relate that to the driving pressure?
I mean, in order to identify pendulift is not very easy.
Right.
It is very complicated because you need to have some methods that are not very easy applicable at bedside. However, pendulift usually occurs when there is high respiratory drive. So indirectly, we can say that this patient may have pendulift if respiratory drive is very high. On the other hand, if you have a patient being calm on PAV and the driving pressure is 10 or 8 or 9 or 11, more or less you are okay in terms of high respiratory drive because there is no such a thing in this type of patients.
Okay. If you could you compare for me the measurement of driving pressure during passive ventilation using an end inspiratory hold and the measurement of driving pressure during spontaneous breathing with proportional assist ventilation plus?
Studies in passively mechanically ventilated patients have shown that there is a relationship between high driving pressure and bad outcome. However, in this study, driving pressure was measured at a difference between plateau pressure, measured 3 seconds after occlusion, minus PEEP level. With PAV, plateau pressure is measured 300 milliseconds after occlusion. And of course, plateau pressure measured at this point is higher than plateau pressure measured at 3 seconds after occlusion. That means that if we are dealing with driving pressure of 12 with PAV, most probably we are dealing with a driving pressure of 10 in studies using passive mechanical ventilation. And the physicians should realize that, for example, driving pressure of 14 is not very dangerous in patients ventilated with PAV. However, we have at this point to be very careful because driving pressure has 2 components. One is lung and the other is the chest wall. That means driving pressure of 10, if the lungs are very, very bad, that means there is relatively high driving transpulmonary pressure. So under these circumstances, if we have problems in terms of estimating elastance of the lung and elastance of the chest wall, we may insert an esophageal balloon to measure the transpulmonary pressure in these patients.
Okay, and I've heard you describe that you're doing that by buying an independent esophageal balloon and hooking it directly up to your monitoring system.
Exactly. I mean, it's a very easy technique, very easy.
All right. Could you do me a favor and compare and contrast for me the differences between pressure support and proportional assist ventilation plus when it comes to overventilation or the tendency to overventilate patients?
Okay. In order to describe this difference, we have to realize that with pressure support, you don't influence, you don't affect the relationship between effort and tidal volume. With pressure support, what you are doing is to increase the minimum tidal volume. Minimum tidal volume is the tidal volume that the patient will receive when he or she relaxes all the muscles immediately after triggering. So as you increase pressure support, you increase the minimum tidal volume. Minimum tidal volume usually actually is approximately the ratio of pressure support to elastance of respiratory system. is not the right one, but the equation is a little bit more complicated. But for practical reasons, you can say, okay, minimum tidal volume is the ratio of pressure support divided by the elastance of respiratory system. As you increase pressure support, you increase the minimum tidal volume, and it is very easy that the patient receives relatively high tidal volumes. This is not the case with proportional assist ventilation, because with proportional assist ventilation, always minimum tidal volume is 0, independent on the level of assist. That means if the assist is high, the muscle pressure of the patient is low, and as a result, tidal volume should be in the normal range, because now the patient is able to control the tidal volume very efficiently.
That's wonderful. So, in terms of overventilation and the consequences, could you address the issues with apnea threshold and sleep fragmentation?
It is very easy to produce apneas in critically ill patients using pressure support ventilation, because by increasing pressure support ventilation, you increase minimum tidal volume, and because respiratory rate, actually the patient does not want to change respiratory rate a lot. So they keep more or less constant respiratory rate, and by increasing pressure support, you forces PCO2 to reach apneic threshold. When this happens, the patient will develop apnea. This is not the case with PAV, because with PAV, as you increase the percent of assist, muscle pressure goes down, and therefore the patient is able to maintain constant tidal volume independent on the assist, and several studies have shown that this is the case. So it is very difficult to produce apneas in patients ventilated with PAV.
And so when we have a problem with overventilation and apnea in the patient, could you discuss sleep fragmentation and the impact that will have on the patient's mortality and morbidity?
Studies have shown, and this is fact, that periodic breathing at apneas are associated with sleep fragmentation and relatively low levels of deep sleep, such as rapid eye movement sleep and stage 3 of sleep, 3 and 4. Right now we have the new definition, which is N3 stage. So sleep is very important, and today we have starting realize that sleep in critically ill patients is very important, because bad sleep is associated with high morbidity and perhaps with high mortality. We don't know yet about mortality, but definitely morbidity goes up. For example, bad sleep is associated with cognitive dysfunction, not right now, but 6 months later, and also is associated with delirium. I mean, one of the causes of delirium is bad sleep or poor sleep in ICU. So morbidity is definitely high if sleep is not good in critically ill patients.
Could you describe for me the differences between using sedation and sleeping?
No, I mean, sedation has nothing to do with sleep. We believe that when we sedate the patient is sleeping. This is not true, because normal sleep has nothing to do with sedation state.
Okay. So we just mentioned the fact that it's very easy to overventilate a patient and reach an apnea threshold when using pressure support or other modes of ventilation. Could you also talk a little bit more about the synchrony aspect of pressure support as in comparison to proportional assist ventilation plus?
I mean, there is no question that PAV is associated with much better synchrony between patient and ventilator comparing to pressure support ventilation. Indeed, studies have shown that ineffective efforts are much less with PAV than with pressure support. Double triggering is, in the reality, does not exist. And expiratory asynchrony is much less with PAV than with pressure support. Not only that, but we have shown that the ventilatory demands are easier to be met when the patient is ventilated on PAV than when the patient is ventilated with pressure support. So we reduced basically all aspects of patient ventilatory desynchrony with PAV, comparing, of course, to pressure support or even to assist volume control.
So what if I'm needing to use a little bit of sedation because my patient is anxious, not because of discomfort from the ventilation style, but anxious because they're intubated, they're laying in a bed, they're really uncomfortable. What about using a little bit of sedation on those patients who are ventilated with PAV?
This is very common, and we can use we have to be very careful in titration, in sedation, because with PAV, respiratory drive actually lead the ventilator to work. However, it is not a problem, provided that you are using the appropriate sedation scales to titrate the sedation. So you can use various sedative drugs, and there is no problem. In our hands, we are using PAV in sedated patients. We don't have any problem.
Thank you. This one is going to be about how to adjust proportional assist ventilation plus when you are, from the time that you put the patient on PAV plus, and then the course it can take, whether you're moving in the right direction towards removing the ventilator from the patient versus when the patient isn't doing well. Could you describe for me the signs and the steps that you take as you're moving through that decision process?
Okay, as we discussed it before, we must be very careful in titration percent of assist and titration of PIP, because these two variables are going together. Initially, we have to give a little bit high assist because you don't know the needs of the patient. So we are starting from 70% and then we titrate PIP. And we titrate PIP because with proper titration of PIP, actually you have the right function of PAV. This is important. Sometimes you may need to change modes. This is not very common. In some patients having problems, especially if the respiratory drive is very high. And then that means that you have done a mistake because it is not the right time to change to assisted modes. Most probably you have to again switch to control modes. And another issue is when respiratory drive is very low. Usually low respiratory drive is due to sedation, so you have done a mistake in titration the sedative drug. These are the two situations that where we have to switch to another mode. And when the patient is ready to wean from the ventilator, with PAV, when you have reached 30% of assist, and when PIP is more or less 5 centimeters of water, then it is a time that you can proceed either using spontaneous breathing trial, or you can extubate immediately the patient, depending on the patient.
So you're saying it's basically equivalent to doing a spontaneous breathing trial?
Exactly. I mean, if you want to be sure, you can go a little bit lower, 10% or 20%, and then you can extubate from this level.
When you're titrating the PEEP level, could you describe for me how you're using the compliance measurement that's on the screen of the ventilator in order to be able to manage the PEEP level?
Okay, I mean, the answer is very simple. You increase PEEP And then you are going to observe what is happening in terms of compliance. If by increasing PEEP you are going to see an increase in compliance, definitely you are doing something good for the patient. So you can go on by increasing PEEP, provided that every time you increase PEEP, you are going to see an increase in compliance. When compliance remains constant, this is the optimum PEEP for this particular patient.
Okay, that's helpful. So could you then describe for me the difference in the compliance measurement that's shown on that screen compared with the compliance that you would normally see on a spontaneously breathing patient and pressure support or something else? So the static compliance measurement versus the dynamic compliance measurement that you would see on, which is what would be available during pressure support or other spontaneous types.
Compliance measurement during PAV has nothing to do with dynamic compliance, because dynamic compliance also dynamic compliance means we have resistive pressure in the picture, you have elastic pressure in the picture, you have muscle pressure in the picture. So it is very complicated and basically is a variable that does not say anything to the physician.
So you're not using that dynamic compliance measurement in order to set PEEP?
Not at all.
So do you know of any other way or any other ventilator that provides for you a static compliance measurement for spontaneously breathing patient?
No, this is the only mode that you can have a measurement of static compliance. Or not static compliance, is quasi-static compliance.
Okay, with that 300 millisecond
Exactly.
How would you compare PAV Plus with other automated styles of ventilation, such as Smart Care?
This is my personal opinion. I'm not a fan of algorithms in critically ill patients, because in this type of patients we have a dynamic situation. And personally, I have to look at the patient when I want to decide a change. So I don't want to have an algorithm that is going to say, okay, this is the time that you have to change whatever. Okay, I don't like automatic algorithms. So I don't like these systems that is okay for normal lungs, but is not okay for disease lungs. And in critically ill patients, we have disease lungs.
Or they probably wouldn't be on the ventilator.
Okay.
Sometimes when we're ventilating with PAV Plus, we can see that the driving pressure is below 15, but the tidal volume is higher than 5 to 7 mLs per kilo.
Mm-hmm.
Could you describe why that might happen?
Okay, because if driving pressure is 10 and tidal volume is 10 ml per kilo, that means compliance is very good. And we know from studies that normal human beings, the range of tidal volume may be from 3.5 ml per kilo till 14 ml per kilo. And therefore it depends on the patient who is going to decide the desired tidal volume for him or her, provided that compliance permits to have this tidal volume.
So if I can summarize that statement, and please correct me if I'm not summarizing it correctly, I think what you're saying is that the patient is sizing the tidal volume to the size of their lung.
Exactly.
In the way that we try to do it artificially
Exactly.
with our 6 mLs per kilo.
Exactly.
Since we're using ideal body weight, but we really don't know how big the lung is at that point.
Exactly. And we have data showing that actually the brain of the patient does exactly this.
So when you're following driving pressure, but you see that the tidal volume is higher than 6 mLs per kilo, you're feeling confident that you're still doing protective ventilation.
Because the patient, for as I told you before, normal tidal volume may range from 3.5 to 14 ml per kilogram. So we may face a patient that for him or her, normal tidal volume is 10 ml per kilo. If driving pressure is okay, we are okay.
Okay. Could you describe for me the differences or the similarities in issues with triggering or any other patient management issues between proportional assist ventilation plus and the other proportional style of ventilation on the market?
NAVA, which is the other proportional mode, uses a catheter to obtain electrical activity of the diaphragm, and the electrical activity of the diaphragm drives the ventilator. It's very similar to PAV, however, in order to work, we need to insert a catheter and to obtain the electrical signal. The triggering system that is used by NAVA is better than flow triggering because it uses electrical activity of the diaphragm. However, in approximately 30% of breaths, due to noise, sometimes they change from electrical activity of the diaphragm method of triggering to flow method of triggering. And this, of course, may create problems. But to be honest, the triggering system of NAVA is better than the triggering system of PAV. Another difference between PAV and NAVA is that with PAV we know mechanics. And therefore, if we are going to have a change in mechanics, we are going to compensate for this change because the ventilator will understand that something changes in terms of, for example, of compliance. With NAVA, NAVA does not measure mechanics. So NAVA also is a nice mode because it's a proportional mode, and of course there are differences and similarities.
If you could go back to the situation where the breath is switching over to flow triggering. So that breath is going to be flow triggered instead of triggered by the diaphragm electrical activity. And then what happens with that breath, the delivery of the breath?
Okay, it may use the software uses the electrical activity and there is proportional breath. However, sometimes because of the noise or because of malfunction of the catheter or whatever,
the catheter up or down.
The ventilator, if there is no clear signal, changes automatically from NAVA to pressure support. This is not the case with PAV because there is no automatic change, except if we have apnea for 20 seconds and then we have the backup of the ventilator.
Okay, so if the patient were to go apneic and proportional assist ventilation plus, the ventilator would supply ventilation with the apnea backup.
Exactly.
Okay. So I would like to thank Dr. Georgopoulos for working with us today and for his very, very experienced, educated opinions on this.
It's my pleasure.
Thank you very
It's my
much.
pleasure.